Hey, it's Dr. Bill with just the tip of urology school. And today, urology school talks about prostate cancer. And we're going to talk about prostate cancer in general, but offer some of the treatments for evidence of confined disease. We're not talking about disease that is metastatic and disease that is only controllable with androgen deprivation therapy. So we're talking about primary treatments for cure. You'll likely see prostate cancer patients daily in your clinic. It's very common. There are a number of different opinions, both from university level professors as well as the lay public on management of prostate cancer, and new studies coming out routinely. So be aware of that. The conventional and unconventional treatments, including nutrition and homeopathic approaches, are routinely mentioned, not only in the literature, but are also brought up by patients and family members in the clinic. The concept of shared decision making is something that really was popularized with the advent of prostate cancer. I think that's a tough responsibility on patients and family. They are exposed to a lot of disinformation and may come to you with packets of information from the web, looking at different approaches for prostate cancer. Uh, Understand that I think it is unfair to have our patients get involved with this, but unfortunately, in my opinion, I'll probably get some heat on this, that it's just something that we're going to have to deal with and bring that up and make sure that patients get their 2 cents in, if you will. Enough editorializing, but we understand that when we diagnose prostate cancer, we have to be aware of PSAs and know what PSAs are all about. PSAs have gotten a bad rap, and over the years prior to PSAs, when my dad was practicing urology in the 70s and early 80s, most patients presented with metastatic disease. Most patients presented with symptoms of bad spread, deterioration nutritionally, loss of weight, back pain, a general decline in normal daily activity. PSAs came along, and we realized that with PSAs and digital rectal exams, that we were finding more prostate cancer earlier and probably treating a lot of patients that didn't really need to be treated. But what we saw was a decline in metastatic disease as the presenting factor. At some point, PSAs became too confusing, and there was a lot of disinformation about PSAs to the point where family practice literature actually downplayed the value and were reluctant to use PSAs in their screening for their patient population, male patient population. What we found was a slow increase in initial presentation with metastatic disease. Not using PSAs, not doing routine digital rectal exams on those patients at risk caused more bad cancer. We're realizing that now, and now we're seeing an increase in interest in PSAs after all of this disinformation that occurred. Bottom line, do a digital rectal exam and get PSAs. They're both complementary. Now, there's no evidence to indicate that we should be getting PSAs on our patients younger than 40. If we have patients who have risk factors, Black males, family history of increased uh, cancers, family history of prostate cancer, breast cancer, and colon cancer, all those patients are at risk. So we should be looking at evaluating those guys with digital rectal exams and PSA greater than 40. And for those patients who we see without a greater risk, we should start at 50. Again, PSA and digital rectal exams are complementary. Understanding the value of serial PSAs, meaning one PSA doesn't tell us anything. We don't know what that patient's history is. We need to look at PSA density, how much PSA per gram or volume or weight of prostate tissue, and age-adjusted PSAs. The older we get, the larger our prostates are, and because of PSA basically being a surrogate for size, those PSAs are going to be greater. So a 50-year-old with a PSA of 4 is very different than a 75, 80-year-old with a PSA of 4, and understand the differences and understand age-specific PSAs. Know that for those patients who are on 5-alpha reductase inhibitors like Proscar or Avodart or finasteride will have, after about 6 months to 12 months of use, a decline by 50%. That is a falsely low level. And so when you see those patients who've been on those medications for a while, double the PSA, and that's the PSA you should be looking at. Prostate biopsies years ago when we were doing them were either perineal punch or digitally directed needle biopsies. We were taking one core on each side. Now we're using ultrasounds and more recently MRI guided biopsies. We know that the more biopsies we take, the greater likelihood we have of finding prostate cancer if there's prostate cancer there. So, Doc, I don't know why you're suggesting a biopsy. I had one 4 years ago. Well, we didn't have the same technology we're having, so that really doesn't count. You go to your mechanic to get your oil changed. I don't need it. I had it changed a few years ago. Same concept. And unlike what most patients believe, there's no evidence currently to indicate that transrectal prostate biopsies will spread cancer cells if there's cancer cells there. And so when we get a biopsy and we evaluate a patient and we look at the number of cores, the number of samples that were positive, we can also look at the Gleason's grade, how aggressive the glands are. You'll learn about staging of Gleason's, how staging of Gleason's grade disease is made. So volume, Gleason's grade, and the genetic status of the patient as far as familial prostate cancers will also all help us in guiding and directing our patients, educating our patients on the form of appropriate treatments. So along with this identification of prostate cancer comes with a responsibility of us helping our patient decide when active treatments are necessary. And there are some definitive guidelines on when active treatments or active surveillance is appropriate. But also keep in mind that a lot of it has to do with patients' own comfort level on whether they want to be treated or whether they just want to be observed. So active surveillance is something that over the years has really become more popular. Think of active surveillance as just that. It's not that you're not doing anything. It's you're actively evaluating the patient to determine when or if progression occurs, and then you can impact change by offering some other treatment. And it's an ongoing relationship with you with your patient, where at least currently, every 3 months we're doing PSAs, digital rectal exams with periodic MRIs and periodic prostate biopsies. So it is active, and some patients will opt out of that program at some point. So it's very important that you continually document what your plan is on these 2-3 month visits and what the patient's desires are. And if at any time there's a question of, and I'm not really happy with this, then active treatment is discussed. The basic definitive treatment that we use surgically is radical prostatectomy, plus or minus inclusion of a pelvic lymph node dissection based on risks. That is the types of radical prostatectomy, and the approaches have varied greatly over the years, but basically it's removing the entire prostate gland. Unlike surgical procedures for benign disease where the capsule is left behind, radical prostatectomy presumes not only the inside of the prostate, the tissue, but also the outside layer, or the capsule is removed. Radical prostatectomy. When you see these patients postoperatively, there are some immediate concerns and some long-term concerns of potential adverse events. DVTs, probably the biggest thing, though becoming rarer, the biggest thing that we need to worry about in the immediate time frame, but also look at and prepare patients preoperatively for the potential of different kinds of urinary incontinence, whether it's stress or urge, as well as erectile dysfunction. Another form of primary treatment, potentially curative treatment, is radiation therapy. We are essentially curing the disease by not removing it as in surgery, but killing the disease with radiation. There's also adjuvant radiation treatment or additional treatments after surgery. Various types of radiation therapy, external beam radiation, brachytherapy or seed implant, and proton beam treatments that can be utilized and certainly nicely outlined in our backup support with the AUA core curriculum. Side effects will include urinary incontinence, erectile dysfunction, cystitis, and proctitis, radiation changes. All are utilized with various intensity of radiation and have their own niche in a particular patient profile. So it's important to have a good understanding of this. And then there are adjuvant treatments, including radiation therapy, as mentioned, and ADT, or androgen deprivation therapy. This is utilized to help shrink prostate tissue, touted to improve surgical margins during radical prostatectomy, all with various protocols of perioperative treatment and combined radiation and hormone treatment for anywhere from 2 to 3 years, depending on the protocol. Focal therapies, including cryosurgery, freezing the prostate cancer, looking at a combination of freezing and thawing to destroy cancer cells, HIFU or high intensity focal ultrasound use, utilizing significant heat to kill the cancer cells. So this is a basic overview of prostate cancer, obviously the most common cancer we see. A ton of literature coming out on a routine basis. involve your patient for shared decision-making as required by the AUA, have an understanding of that, but don't let that bog you down in the message that you're giving the patient and the family. Other things that we'll talk about in subsequent videos on how to handle advanced prostate cancer, to look at controlling cancer cells with a combination of hormonal blockade and improvements in bone strength and improvements of even utilizing chemotherapies as well. So fascinating disease with a lot of facets to it. Look at your information and up to date in the AUA core curriculum. Dr. Bill with just the tip of urology school talking about prostate cancer.